Good afternoon, everybody. This is Ken Murphy from GP Connections. I'd like to welcome everyone aboard, especially Mr. Chris Tanti from Headspace. We are about to kick off, and we do have a couple of other people joining us, and it is noted that we've got a few people that have signed in anonymously, so they're not showing up on the register there, but they're hiding in the background, so welcome to those people as well. I'd like to hand it over to Chris to get it going, and we can get the show going. All yours, Chris.
Okay. Hi everybody. I think I've missed the introduction. I got the end of the introduction. I've just been in another meeting, and just want to thank everyone for joining. The last time I did this I was in New York, and I was presenting to a whole group of services from around the country in the United States. It was a very different system, and I had technical support, and as I'm not technically savvy, I might miss a few things, particularly when they come from you in questions, but it seems so far that I can work my way through it. So essentially what I'm going to talk to you today about is provide you with an overview of Headspace and how the organisation interacts with and intersects with primary healthcare providers. For those of you who don't know anything about Headspace, we were established in 2006, and it was a fairly cumbersome organisation that was set up. It was set up as part of the University of Melbourne. We were in the Faculty of Medicine at the time, and we weren't an independent company at that stage, obviously, but there are a number of governing groups that were established by the Commonwealth to oversee the implementation of Headspace. And essentially that level of complexity made it very difficult to do our job, but do our job we did. And we ran a round of, our first round of centres was primarily 10 centres funded across the country, 50% of which were in metropolitan areas and 50% in rural and regional areas. And from there on, we sort of continued to expand. The next funding round was for 20 centres. We were originally funded to do 30. We've now been expanded, and the money has also significantly expanded. But by the time we finish this current contract, which is 2014-2015, we'll have established 90 centres around the country. It was primarily funded to work at the primary care end of service delivery, and hence a lot of the involvement within Headspace facilities is with the what were formerly known as the divisions of general practice, but the Medicare locals are also now a very critical part of what we do. But there are a number of service platforms that needed to contribute to Headspace to make it the sort of model it is. And in its ideal sense, what we were trying to do with Headspace was to create a really robust platform from which a whole lot of services could be provided to young people. And those services could have been funded by us or funded by other governments, like state governments and local governments, but primarily delivered through a Headspace centre. So it's a one-stop model, co-located model, but it is at the primary care end, with the overall vision to improve young people's mental health, social and emotional well-being through the provision of high-quality integrated services. One of the things that we didn't want to do in this space was duplicate the existing complexity, and we continue to work hard to make sure that our services are very visible and that they are easy to access. So there is no referrals required to enter a headspace centre, as is often the case with seeing specialist services, and that there isn't a very complex process to entry as there is with public mental health services. So we sort of wanted it to be similar to the design of a general practice in lots of ways, and that's certainly how I conceptualised it when I first started. The need has been very well documented in this country, particularly by people like Pat McGarry. And what we know is that 75% of mental health and substance use disorders start before the age of 25, and so a specialist focus or a targeted focus on young people is required if we're going to have an impact on some of the secondary problems that may emerge from for a young person who hasn't been treated. We're clear that disorders have a trajectory or stage, and the idea about headspace, as it is in primary care, is to get in at the earliest possible point, and hence that my sort of comment earlier on about making sure that there were no barriers to entry. We're also clear that many young people don't seek help, that the first port of call is generally their families, which is terrific, but from there there's no real clear sense of how they can engage expertise and engage support. I was recently working with a friend of mine whose daughter became psychotic in Bega in New South Wales, and for someone who is very involved in the welfare sector, it was a real challenge for him to navigate his way through the system. So they had the knowledge, but they actually didn't know how to gain access to care. And so one of the things that we are very keen to do is to create knowledge and to empower people to access care, but importantly to empower young people to seek care themselves. So the majority of our referrals into headspace centres, over 60–65%, come from young people and their families, which is terrific. We're also clear that many young people feel uncomfortable with the existing service offerings, and that really is about most of the public services being geared towards the most complex presentation. And so the public mental health system really has very clear, and this is different from state to state, but I'm also very clear that you've got to be very, very sick to enter a public mental health system, equally to access other systems, vocational support and other supports within the community, housing, etc. You've also, there's a pretty high bar to get over. So again, it really is about creating youth-friendly environments that young people feel comfortable in, that will endeavour to meet all their needs. And we wanted a holistic focus on care. So in a similar way that GPs operate, a primary care practice operates, we wanted to be able to meet all the needs of young people as they came through, not just their mental health needs, but a whole range of needs, including support around family difficulties, relationship difficulties, difficulties at school, difficulties with vocation, sexual health issues, a whole range of things. We want to be clear that we can provide, and that moves depending on what young people are telling us as well. So we make sure that we receive feedback from young people about whether we're actually meeting all the needs that they're presenting with. So in a sense, it's a new paradigm, it is a mental health service, and albeit an expanded mental health service for young people aged 12 to 25. It is about early intervention and early help seeking, but obviously there are no barriers really. If someone has been ill for a long period of time, we're not going to knock them back on the basis of how unwell they've been, for how long they've been unwell. I mean, certainly in the early days of Headspace, there were people rejecting patients because this was their third suicide attempt, and they rejected them on the basis that it wasn't early intervention. I think that is complete nonsense. And so now we talk about our only criteria for entry is 12 to 25. We don't really talk about early intervention because we know that's open to misinterpretation. We want to make sure that we remove the barriers to care. There are no geographical catchment areas as there are in the majority of public mental health services. So a lot of our young people are travelling great distances to come to Headspace, which is fine if they're able to do that. We want to provide a service that's fee-free, if you like, free or low cost, and there are various ways that we do that, and each centre is different in relation to that. And it really is about maximising the use of existing resources. I mean, there is some waste in the system. There is lots of duplication, and even in small country towns that I've visited, half the services didn't really know that other services existed in that country town. So, for us, really, it's about knowing that there is a big problem out there in relation to youth mental health and maximising the use of the existing funded services. We have young people involved in every centre as well as at a national level. So we have a national youth reference group that is comprised of representatives from each of the centres. And we've recently developed a family and friends subcommittee of the Headspace board, which looks at ways to be more inclusive of families. I won't spend a lot of time going through this, and you can certainly get this information from our website, but the majority of centres, as you would expect, are located on the eastern seaboard of the country. We do have centres in Alice Springs and Darwin, a smattering in South Australia and Western Australia, obviously, and that will continue to grow. By how much, I can't tell you. At the moment it's 90. There obviously will be a cap in each state and territory, and that'll be population and needs based. But ultimately these are the decisions of the Minister. In terms of the model is somewhat complex, and sometimes I think unnecessarily so, because I have to manage the damn thing. But the areas are defined by the Minister. So in terms of, there is some modelling on how on population, based on population need and morality and a whole range of other things that are too complex to go into. So that throws up areas that should be funded. We should provide Headspace funding for. There is a grant application process which is generally led by one organisation who must engage other service providers in the community to be part of Headspace, to be part of that Headspace platform. And we generally refer to that group as a consortium. The consortium, the lead agency provides us with a sort of, an expression of interest, and then they move to, if they're selected on the basis of that expression of interest, then they move to business planning. The key things in our sort of views about a Headspace centre are that the location's got to be good, because the majority of young people that we see don't have a licence, and so access to public transport is is important. There must be 4 core streams represented, i.e. primary care, physical health, mental health, drug and alcohol, and vocational and educational support. Drug and alcohol and vocational and educational support we haven't done too well on, but we continue to work with those services to make sure that we're providing the service that we want in that space. Vocational services are tricky because they're funded in a way that is reliant on outcomes, which is obviously very important, but it might not be the outcome that the young person wants. So there might be a job placement that is actually contrary to what the young person wants, but that's a tick for the vocational service. So this is a very complex space. It must have a multidisciplinary team. We are lucky enough to have a range of general practitioners involved in Headspace. None of them are involved full-time. They're involved on a sessional basis, so they might commit to 1 or 2 sessions a week. And generally the feedback from them, and we just ran a couple of days with all our GPs, bringing them into Melbourne to have a discussion about what works and what doesn't work, is that they really like the idea of being part of a much bigger thing, being part of a multidisciplinary team, working with the support of allied health, and they like the specific focus on young people. So there is a real interest in what it is that we're offering, and so that has some appeal to particular GPs. We have 40 operational centres currently, 15 that are about to open their doors, taking us to 55. We've just selected the next 15 beyond that, so it continues to expand. So in a sense, on a percentage basis, Headspace is growing by 30% plus per annum, which is a significant growth story, really, and doesn't come without its headaches, but it's terrific that we're able to put this on the ground in the way that we're doing it. The other thing that we've been successful in getting government support for is eHeadspace, which is our online counselling service, which runs largely it's a 24-hour-a-day service, and it's 7 days a week, so 365 days a year. But there are various components that kick in at various times of the day, and so it started off as a pilot program in remote WA and was expanded to cover the whole country. So there is an online counselling service. There's a telephone service associated with that. There's an email component, so people can send us in emails and we'll respond to those. But it is a really, really terrific service that has that grows at the most rapid rate. And a very interesting experience for me, who's sort of come from a clinical background as well as a management background. I was quite not critical of this space, but wary of this space from the point of view that I think there is a lot to be gained from seeing the patient face to face. But actually, young people are very comfortable, and younger clinicians, I might add, are very comfortable communicating in this way. And it is interesting what you can elicit online. So we have a multidisciplinary team that provide e-therapy. It's not a crisis service, we say, but actually it is a crisis service. Young people will contact us when they're in crisis. Why else would they contact us? We do provide a whole range of therapeutic interventions that might be provided over a period of time. So it is not just a triage crisis service. It is really about a young person presenting in crisis, and then we assist them online to deal with that particular crisis, and then they move on, or we in turn move them on to face-to-face services, particularly to Headspace centres where there is a Headspace centre. And you can go to the website and have a look at that. It is a separate website to the Headspace website, although there is a link, and it's the eheadspace.org.au. The other area of support, we've got federal, and by the way, all our funding comes from federal governments, state governments don't really, I mean, in Victoria they have made some contribution, but the majority of money comes from the federal government, which in a sense makes it much easier to operationalise the model. The other thing that we've been successful in attracting is money to work with schools and young people in schools in the event of a suicide, or so the idea is prevention and postvention, working with schools to make sure that they're ready in the event that a suicide occurs, and as we know, these are all too common occurrences, but also working with a school in the event that after the event has occurred, and supporting the school and setting up systems and setting up referral pathways and working with students and working with families. In some instances, this is a fairly complex process. There is an example of a cluster suicide in Victoria at the moment where I think we're up to 18, 19 kids in one of the outer suburbs in the southeast, and as you can imagine, there is no quick fix in a situation like that. There are 94 different secondary schools, 94 principals, 30,000 young people. I mean, it is very complex, and the reach is huge. So that community will require a very long-term intervention, but in other instances, the intervention will be fairly brief. And the overall idea is for us to contain the situation, so minimise the risk of creating a cluster in the event that there is a suicide in the school, and making sure that young people know where their supports are. It's the interface between health and education. For any of you who have done this sort of work, you'll know what I'm saying is quite strained. I mean, there is a suspicion and a healthy disrespect for each other's patch, and so it has been difficult to get traction. But actually, at a very senior level within government and within the schools and health settings, there, I mean, it's very easy for Headspace because I control that. But in terms of schools, it is very clear that there is support required, and so long as the support is real and we can, keep our promises, there is a very, we have managed to get really good participation and buy-in from the education sector, which we hope continues. And I think we've set that up the right way in terms of a fairly long consultation process. So that is really hitting the ground this year. There's been a whole lot of work that's occurred in the background developmentally, but that's hitting the ground, and there are teams in every state and territory. And each of those teams is co-located with a Headspace centre. What we're hoping to do now is integrate all of that at the same time, expand at the same time. Developmentally, everything's at a fairly early stage, but I think we have there is a reasonable chance that we'll be able to do that, making sure that people can make use of our services regardless of where they are. I mean, one of the things that I'm very committed to is making sure that a young person in distress is able to access a service regardless of whether it's real time or over the internet, and that the barriers to accessing that service is minimal. I've just put a slide up here that has nothing on it, and I'm not sure what it's doing there, but that could be slide 12. Wendy, I understand that we had an issue with slide 12, but if this is slide 12, sorry, just let me get organised here, and it is slide 12. What you would be seeing is a lovely graph that sort of chronicles the number of clients that we've seen, and so in terms of unique clients across the system. And so you've got to bear in mind that we started in 2006, but it was actually really 2008 before these services hit the ground. We've seen 83,000 young people, 83,197 young people through our centres, and since East Headspace was established some 12 months ago, we've seen 11,000 young people. So the growth in eHeadspace is pretty astounding, and that continues to grow by about 20%, 17% month on month. So we anticipate, we're already at capacity, we anticipate that will continue to grow over time, and that's something that will need, I think, additional support from government for. The Headspace school support contacts have been around 418, but given that we've just hit the ground, we hit the ground toward the end of last year, and it was launched in December last year, but given that schools are now coming back, we would anticipate that number will increase dramatically. General practitioners are a really key part of what it is that we're trying to do, and I mean, in lots of ways, the centres have conceptualised this as, you know, having access to the allied health MBS items and being able to refer through to allied health within a Headspace centre. But actually, it's much more than that. It really is about making sure that this sits in a primary care space, and that we view mental health in its much broader, in a much broader, holistic way, and in a much bigger context. I mean, often psychiatry is very specifically focused. You know, if you walk into any public mental health service, you can be pretty clear that the majority of people in their facilities or on their books have psychotic disorders or borderline personality. The people that wouldn't register are the young kids that are struggling in a family context, struggling with exams, or struggling with relationships, you know, struggling with their own identity and coming out, and a whole range of sexual health issues, as well as some more sort of complex mental health problems. This is the context we're in. This is the context that most primary care practitioners are in, and I think it's fair to say that it has been hard to recruit general practitioners, simply because most of them are very well established in their own practices, and they're quite happy to refer to Headspace, but not necessarily be located in a Headspace centre. I mean, my preference is always that we have as much of a general practitioner's time as we can within a Headspace centre, because we really, one of the things I'm clear about in my own clinical experience is that we know that when you refer a young person to another service, that you know, the young person may be interested at that particular point in time, but given the complexity of their lives and given that they have a lot on, that actually it becomes a second, third, fourth order issue for them, and they generally don't follow through. And one of the things that we're clear about is that we can have, if we can have all these services under the one roof, then we're more likely to be able to establish a relationship between the patient and the centre, as well as the practitioners within that centre. And I think it is really important that young people are comfortable in the environment they're in order for it to stick, in order for them to get the attention they need. But you know, my career in this space has certainly led me to believe that unless the services are co-located, then it's pretty much hit and miss. You know, your young person may be taken along by their family, but often if you're reliant on the young person to get themselves there, then generally that won't happen for a whole range of issues. So the Australian General Practice Network, which is still the Australian General Practice Network in spite of the fact that we have Medicare Locals now, is a member of the Headspace board. We have two general practitioners on our board. One is Rob Walters, who's a GP from Tasmania, and the other is Lewis Peachy, whose people come from the Cairns area. In fact, he is located in that area, and he's an Indigenous general practitioner. who's just come on the board recently, and he's a terrific guy. So the board also gets the perspective of the general practitioner, and it is always factored into the thinking of what we're doing in the headspace context. I guess there are a range of opportunities for GPs in Headspace. We've just employed a general practitioner to work with us, and essentially this is about increasing the making sure that we have a dialogue with GPs in a way that makes sense for them, and developing a relationship with GPs for the organisation at a national level. But it's also about providing some online support, and that's a pretty scary place for him to go and for us to go. But what with the feedback that we were getting from young people is it would be really good if I could talk to a GP about this online. So we're thinking about how that might work. I think it's true to say that there is there's a practical value of having a GP in the Headspace Centre, and that's a bit about what I talked about earlier on, the allied health engagement through the MBS, and our model does rely on that. I mean, the only way that we can deal with what is very high demand in this space is through the MBS, not through the money we receive from the Commonwealth to set up Headspace centres. So there is a practical, pragmatic sort of part of it. But the other is the bit that I talked about earlier as well, is that the maintaining the broader focus on the holistic needs of people, and young people in particular in this case. And it's fair to say that there isn't a lot of sophisticated thinking that has gone into how we engage GPs, and because we've had a lot on our plate over the last 6 years, as you would imagine. But the 2 days that we ran with the GPs that are currently engaged provided us with a lot of information about what it is that that makes Headspace a good place to work for them, but what it is that we can do to improve that. And so we're continuing to have the discussion through Claudio, who's our GP, to work on ways to improve the way we work with GPs. So what, I mean, and it's true from the discussion I had with GPs, what in our Headspace 2 days was that, some of them do different things. They might operate in a similar way they operate in their general practice, but they might want to do something completely different to the way they operate in their general practice. So some of them are much more interested in counselling. Some of them are interested in getting their assessments right and their formulations and reviews right, and that really is also about having access to psychiatrists and people who are specialists in this area. It is, in a sense, a more focused way of thinking about the patient population. The other thing in Headspace is that it's not long-term care. It's a brief intervention, so there is quite a lot of throughput. The majority of clients come to see us for between 6 and 9 sessions and then move on. This is not a system that's akin to the public sector. We don't do case management, although ultimately that model might change as the complexity increases with the client group that we're seeing. The majority of clients, I might add, come to Headspace for depression and anxiety. That is the most frequent presentation. And so, but you also get kids attending with psychotic disorders as well, of kids who are, coming out, or a range of presentations. And so from that perspective, the work is very interesting. In lots of ways, I think about it, it's akin to the way I operated within a university environment when I was working in a university counselling service where, and again, it's similar to a GP practice where, anything walks through the door and you have to do with what walks through the door. Whereas when I was running a mental health service and working in one, it was very clear that everyone was going to have schizophrenia or a borderline personality disorder, so that the the work is rich from that perspective, and we hear this from Allied Health as well. It's a breath of fresh air. It just mixes things up a bit, so there isn't the constant level of tension and anxiety around the client group. And this has come from the GPs that we engaged over the 2 days, that one of the things that they're clear about that they enjoy is being part of a multidisciplinary team, working with other mental health providers, being able to focus for that particular period of time on young people. They don't want to do it all the time, but it allows them to specialise for a brief period of time. There are generally longer consultations. They like the environment that they're in. They like that our approach is evidence-based, and that there's an opportunity to innovate. The other piece to Headspace, and I touched on it earlier on, was the importance of the youth reference groups in each of the centres, and all of them have specifically reported back that GPs are a fundamental part of. Often people don't have access to psychiatrists, and their relationship is with their general practitioner, and they consistently report the importance of the relationship between the doctor and patient, and that obviously dictates the way we think about that, and the policy we put in place within Headspace centres. I've come to the end of my presentation, and I think we had an hour allocated, so I'm still not sure how many people are online. I think it says 6, but I'm happy to take any questions. And if I can get a sense of who you are as well, that would be really useful. So the question I've got, I assume people can see this as well, is are GPs from outside the districts able to refer? Yes, absolutely. So there are no geographical boundaries to anything that we do, either accepting referrals or clients being able to sort of hop on a train, come down an hour to go to a Headspace centre. There is no restriction. The only criteria is that young people are 12 to 25. So I've got a question here about the remuneration for GPs, which is a really good question, and we've had the same issue with psychiatrists. The remuneration for what we try to do is, but obviously this is entirely up to the GP, is we try to keep everything to bulk billing, and we realise that that's not great, but there are ways we're making sure that we understand the MBS well enough to make sure that we maximise the revenue for general practitioners. The thing that we try to do to compensate is that we offer secretarial services and the consulting suites free of charge, which assists in your bottom line. And it might be that in a particular catchment area there is a capacity for patients to pay out of pocket, but it is very difficult with young people who don't have the disposable income. But if there is if the parents are clear that they're going to the Headspace Centre, then generally out-of-pocket expenses are okay. But it's only if the patient hasn't informed their parents and they have no cash that might be a problem. But certainly there are GPs that are charging out of pocket, and I don't know that you can get in to see a GP who doesn't charge out of pocket. So the way we try and compensate the GP is through infrastructure support.
if there are no other questions, I'd just, on behalf of GP Connections, like to say thank you very much for your time. I appreciate the time, and you've come out of a workshop particularly for this, so I do appreciate the time and the effort that you've gone to, and I'm sure we'll be in touch.
No problem at all. And I guess if people did want to contact me on email, pretty easy to do that. It's ctanti@headspace.org.au. So I'm more than happy to field questions later on if people should have them.
Very much appreciated. Thank you, and we'll sign off now. Thanks a lot. Bye.
No problem. Thank you.